So now we're going to move on to another exciting speaker. In fact, two exciting speakers. You get two for the price of one this time. We have Twila Brase, who is an RN, a friend and longtime colleague, the president and co-founder of the Citizens Council for Health Freedom, and Gina Malik will also be here with us. Just to tell you a little bit about Ms. Twila Brase. The CCHF, if I may use an abbreviation at a medical conference, is based in St. Paul, Minnesota. In August of 2009, Modern Healthcare named Ms. Brase number 75 on the 100 most powerful people in healthcare, which is interesting and definitely thought-provoking. In 2000, Minnesota Physician Magazine selected her as one of the 100 most influential healthcare leaders, which is another exciting achievement. The Council's efforts have been vigorous and are for individual rights and have helped and supported 34 states say no to Obamacare exchanges, which is exciting if you're not a believer in those exchanges, certainly. The CCHF also has stopped government-issued treatment directives and added informed written consent with regard to the government wanting to access patient data. Because we all know, as we've seen multiple data breaches lately and long-term, the government is not immune to data breaches. That's for sure. Having said that, CCHF's efforts have led to several successful parent lawsuits in Minnesota and Texas against the illegal storage, use, and dissemination of baby DNA, which is an emerging technology that's being used, and it's important to maintain privacy and individual responsibility in care. Ms. Twila Brase also received a special award relating to the work she does with the CCHF in October 2013, and the Eagle Forum's Eagle Award for Minnesota. And she also provides daily commentary to 350 radio stations in 40 states. So I've got to hand it to you. I have my hands full with one. So thank you. If you ladies want to come join us up on the podium, and we're going to talk about what we do for our patients. Thank you. Thank you. Thanks, Gina.
Thank you very much for inviting me. Again, Twila Brase, Citizens Council for Health Freedom. I'm here with Dr. Gina Malik. And we are going to have a discussion about what we do for our patients. Now, our organization, to let you know, I was an emergency room nurse, and but have been running this organization since I helped to start it about 21 years ago, but still quite remember what it was like to take care of patients. I think what we're going to do is we're going to have a discussion between the two of us. We have a lot of patient care and information about policy that we think will be interesting to viewers, and then we'll also have some questions at the end if there should be any. So to start this discussion off, I'd just like to say that happening today is a dramatic change in the way that medical care is delivered. And it's happening in ways that the American patient doesn't understand, because it's really happening, for the most part, outside of their viewing, outside of their reality. But it's happening in a way that a lot of physicians do understand, and hospitals do understand, and governments do understand. And what has really transpired here is that outsiders have taken over the practice of medicine in a variety of ways. And this is what patients don't understand. They have, for instance, and it's not just health plans, but it's also corporate hospitals, and it's also big government and big business, and sort of working collusively together against the patient and the doctor. So some of the things that they have done are that now the corporate hospitals are buying up clinics and employing doctors, which makes the doctor an employee not of the patient, but of the hospital. Then they are forcing them into the electronic health record, the interoperable electronic health record, intruding on the patient-doctor confidential patient-doctor relationship. They're putting treatment protocols into the electronic health record and then tracking the physician's use of them and making it more difficult for the physician to do the kind of treatment that they want to do for the individual patient, measuring their use and perhaps penalizing them financially for not complying with whatever happens to be on the computer rather than following their own critical thinking, using their own mind. So in the measurement system, the best doctor can be scored as the worst doctor just because they're using individualized patient care rather than computerized medical decision making. There's also the training of new physicians to toe the line the way the corporate entities want it to go. There's hiring of ancillary staff so that sometimes today patients can't see the doctor that they want to see, but they have to see a physician's assistant or nurse practitioner. There's nothing wrong with those two professions, but again, the patient should be able to choose to have a doctor. They're putting scribes in the they're putting scribes in the clinics to take the notes about what you talk to about your doctor, with your doctor, and they are taking your data without your consent through the electronic health record. So we're going to have a discussion here. I'm going to ask Dr. Malik some questions, and then she's going to have some questions for me. And I hope that what happens here is that you have a better sense from the inside of what it's like to take care of a patient. I like to say that the only reason we have a healthcare system is because we have a patient. If the healthcare system doesn't work for the patient or is adversarial to the patient, we don't have a healthcare system. We have something completely different, and perhaps it is just that the patients and the practitioners now are becoming essentially pawns for those who want to profit off of them or for politicians who want to get votes. So that's my concern going forward, and I think maybe you can listen to some of the inside information from Dr. Malik and then some of the policy information from our organization. So Dr. Malik, tell me about yourself.
What a loaded question, huh? At this point, I started my professional career as a nurse. I had my bachelor's and went on for my master's. Along the way, I did go to St. Louis medical school and was interviewed. And the chief of medicine at that time told me to go home and get married and have children. My confidence wasn't quite as good at that time, and so I did. I got married, I had 3 lovely boys, and I continued my work in nursing. And in particular, I loved oncology, and I worked at MD Anderson in Houston for a year, and then went on to the VA in San Antonio. Once again, the urge crept up that I wanted to go on to medical school. I loved working with house staff, and I always worked in an academic hospital. And so this time, no wasn't an answer. And I did all the prerequisites, went back to school for organic and physics, and took the test and went to medical school. And so my whole goal for going in, though, was solely to go into oncology, because I found myself at that time as a single parent of 3 boys, and that was my passion. My mission was, that was what I wanted to do, was to help lead that care in the intimate relationship in a private room with that patient.
So when you look at medicine today, I think a lot of people think that there is an ethical line that physicians have with their patients. There's an ethical relationship, there's an ethical responsibility, professional obligations of the doctor to the patient. How would you say that what is happening in healthcare today has impacted that?
That's very challenging, because as hard as I try to keep that personal, intimate relationship, and at this point I have to say from my standpoint, I'm still trying to protect those patients from many of the things that I have to deal with when I leave the room. But clearly there's been some dehumanization of physician, of the practice of that intimate relationship. There's wedges put between. Patients are asked to choose. Insurance companies accept or all of a sudden write us say, no, you're no longer a provider in our company. And it disturbs that personal relationship that we have, and patients are forced to choose insurances and to move on, perhaps to another physician. So you feel as though we're all replaceable, whereas that relationship was never replaceable. I feel that that core value of a physician is to be an advocate for their patient. If we're not an advocate for the patient, we're not a physician for that patient. And so those opportunities to say, when I'm asked to prior authorize, for example, a chemotherapy regimen, and it's a standard, nothing fancy, nothing out of the ordinary, and they ask me for the page from the NCCN guidelines. And the first time that was said to me or sent back to me, you know, I grumbled and I looked it up and I gave it back, and yet I was very frustrated, but I thought I have to do this for this patient, otherwise it delays their treatment, it delays their faith, their trust. But the next time it came across, I learned. I said, you look it up. And I got it. I still got the protocol, right? And probably faster than I did the first time. It takes sometimes, it's a power struggle, and then that gets into legitimacy, and that's where we are.
Mm-hmm. So what was the first thing that caused you to worry about where care is going today? You know, you became a physician, you started to practice. What was the first thing that made you go, uh-oh, I think we may have trouble in the future, or trouble soon?
Well, it probably still is. I still practice fairly similarly to what I did when I first started. Now remember, I graduated late. I went back to school late in life, so I graduated in '95. So I've only been out 20 years from my fellowship. The changes since that time, obviously, are EHR, meaningful use. Because I'm a solo hospital-based oncologist at this time in a critical access hospital, they've been gentle with me, the administration. I've valued to them, and I understand that and I respect that. However, meaningful use is coming. So with that being said, I'm still dictating. So I can spend as much time as I want with a patient, but I know my colleagues who are doing internal medicine and family practice are not as fortunate. They're given 10 and 15 minutes. They have to have the thing put on a computer screen. And so that's a great interruption into care. And I would say I've seen that over the last couple years, and it's coming for me as well.
So if you could stop three things, excuse me, if you could stop three things today that would really have the most impact in bringing back the patient-doctor relationship, the dignity of the patient, the ethics of the physician, what would be those three things if you were queen?
Yes, and Regina means queen. So meaningful use, numbers over quality, numbers over quality, which is whether anybody says it doesn't exist, it does. The insincerity of prior authorizations. There's no consistency from one insurance to another. And then the loss of legitimacy, which is fairness and a voice to be heard.
So my guess is that listeners maybe, or viewers may be wondering about when you say loss of legitimacy, what do you mean? And they also may be wondering, what does it mean by numbers over quality? I think you should explain those two.
So numbers is physicians in offices, particularly corporate or hospital-based, are asked to see a certain number of patients per day. They don't care how many problems they have, or you are asked, well, this patient has diabetes, heart failure, and hypertension, and you're almost forced to say, I can only deal with one, and then you have to come back. That's loss of job time for that patient. It's loss of resources, and then they get a mark against them, right? And it's a constant factory-like work. It's a business instead of the care that we all so passionately desire.
So patients don't wish to be on a conveyor belt.
They do not. They're widgets right now for many.
But your sense of the matter is that we are just going closer and closer to more the conveyor belt sort of treatment system, as opposed to sitting down with the patient, actually being able to spend enough time and answer all their questions that they may have, and actually questions that you as a physician may have, but when you're watching the clock, maybe you can't afford to watch. You can't afford to ask that question.
And it's true, because in all reality, diabetes in you and diabetes in me and diabetes in one of you is very different because of your place in the family, your life, your work, the concerns you have, the diet you have. Those deserve more attention than here's your prescription and on you go.
Yes, they do. So what in particular, just give me one thing in particular that you're doing today to protect your patients. Do you tell them anything? Do you show them a little bit about what's behind the scenes and maybe how they can protect themselves, or is that not necessary yet?
I think I do. I think at this point I've learned I can only protect them so far. I think they have to also be at the table to help move this health system in the proper direction. I think they have to be educated as well. Most of them are in a panic mode. They're fearful. They want to be cared for, and so they'll run from one to the next. So I do believe that. I do tell them, I do share with them, this will take some work, we're going to get it done, let me tell you the process I will go through, and let me tell you what occurred with each step. But that's also time that, if everything's put in a dollar sense, you can't look at healthcare that way. It's not a dollar to spend down time and talk with someone, and they share with you their most intimate thoughts and questions about their health and their life.
Right. Well, those are the questions that I have for you, and I know that you have several questions for me.
I do, Twila, I do. Tell us about Citizens Council for Freedom Health.
Citizens Council for Health Freedom, and I will just get this from here, which I forgot to pick up, because I have just a few PowerPoint slides just to give an idea of what we have done over our time. We have been around for 21 years, and we're probably known most for our privacy efforts. And the reason why privacy is so important to our organization is because we understand that he who holds the data makes the rules. And as a matter of fact, when I think about what happened with Obamacare, the Obama administration understands this as well, because they've made comments of the effect that basically they put in the electronic health record mandate, and the essentially $30 billion of appropriations to implement the electronic health record, they put that in the Recovery Act in 2009 as the foundation for Obamacare. And so they understood that the only way to control the practice of medicine and to really profile patients and doctors was to get access to the data. So because our organization our mission is to support healthcare choices, individualized patient care, and medical and genetic privacy, we spend a lot of time looking at the data and trying to figure out how we can bring the controls back to the patient and back to the doctor by giving the control of their data back to the patients. We understand that their data could be used against them. So some of the things that we have done are, let me see if this works here. I do the first one, yes. So here's something that we accomplished just this session in Minnesota. We work at both the national and the state level, is that a bunch of psychologists came to us and said, Minnesota has a mandate that everybody use electronic health records. Now, they're the only state that has that mandate. And what we managed to do was to get an opt-out, an exemption for all solo practitioners and for all cash-based practices, no matter how many practitioners were there. This is part of what we call our wedge of freedom that we believe needs to be built in healthcare, a legal zone in which patients and doctors can work together without all the intrusions that the government and others want to have and put into place today. Here's another piece of what we have worked on. We created the only diagram of the Obamacare exchange system. The exchange is really a national exchange, and the original intent was that every state would create one so that the federal government didn't have to spend the money, and it would just be a feeder system into the Federal Data Services Hub, and so it's just one big national system. And this has been used and has been put even on a member of Congress, put it on their website, on their homepage. We also have worked against Obamacare enrollment because we understand that the only way to essentially stop Obamacare is to either defund it or destabilize it. And destabilizing it means preventing the dollars from coming in. And if you prevent enrollment, you prevent the dollars from coming in, and that can destabilize it. So we showed the 3 legal alternatives to Obamacare enrollment. We also have a campaign. This is a website from hhs.gov, but our campaign is to tell the public that they do not have to sign the HIPAA form. Most clinics, most hospitals think they are required to sign the HIPAA form. And this is the HHS webpage that tells doctors and hospitals what to do. It includes information for the patient about why you're being asked to sign, but it also says for the doctors and the hospitals, if patients refuse, what to do. So we have a national campaign about not signing the HIPAA form and letting people know about this page. And then we're the only organization in the country working against the government storage and use of newborn DNA for research on babies at birth and all citizens across the country through that program.
So, Twila, what do you see as alternatives to the Affordable Care Act?
Well, as I mentioned, we have this, I'll just move this off of that picture there. But as I mentioned, we have this idea of building a wedge of freedom, a legal zone in which the patients and the doctors can work together. They can work together without an electronic health record. They can always use cash. They can always take cash. There could be charity in that zone. There could be a charitable hospital outside of all the regulatory morass that is today Medicare. So Medicare today has around 132,000 pages of regulations. Obamacare has around 20,000 and growing. And so when we look at what can be done, we believe that this legal zone has to be created. We see this wedge as a place where eventually patients who find that they cannot get a doctor who works for them find that in this wedge is a doctor who will work for them, who will spend time with them, who will answer their questions. And they'll start being willing to pay their own cash and go into this zone. In this zone is also the health sharing organizations, which are exempt from Obamacare, and which also pay cash to their practitioners. In this zone, we also believe is where direct care will happen. And we just see the ability for this wedge to grow and grow and grow and encompass more of the entire healthcare arena. But the other thing is we have something called the 5 C's as a solution for healthcare. The first being cash. And so that we have, for all minor and routine care, people will pay cash. They won't pull out their insurance card. Your doctor will call you by name. The staff will call you by name. The first thing that they will do is talk to you by name as opposed to asking you for your card. And the second thing is catastrophic coverage, and we believe that that should be a defined contribution. In other words, a certain amount of money that you get for a diagnosis, and you can shop around where you want. The third is confidentiality, because he who holds the data makes the rules. The fourth is compassionate care. And the third is charity. The fifth is charity. So we believe that the whole healthcare system, the patient, the doctor, was all built on a charitability. We can't lose charitability. We can't lose charity. And even people who are covered are going to find a need for charity. They're going to ask the doctor to do what their insurer refuses to do for them, what the government says that they can't have. We can't lose the charitability of healthcare, or we lose healthcare. One of the things that I like to say is we are moving from the mission of medicine to the business of healthcare, and that's not a friendly place for a patient. And the only reason we have healthcare, again, is because of the patient.
That's great. That's well said. You mentioned Medicare. What are the changes in Medicare that are going on currently?
So I think there's some interesting things happening in Medicare. The trustees report recently came out and talked about that Medicare is going to be solvent until 2030. But what we know from Obamacare is that a lot of the Medicare dollars are being taken out of Medicare, which means that there are fewer dollars to take care of the Medicare population at a time when the Medicare population is booming with the baby boomers. And so there's 10,000 people coming into Medicare every day thinking that they have essentially a program waiting for them that's going to meet all of their needs. But the other thing that the trustees report said is that at least 30% of the Medicare recipients are going to have to pay up to perhaps 52% higher premiums to pay for the additional costs. And it did note that at Medicare Advantage, American taxpayers pay more for Medicare Advantage. Well, Medicare Advantage are the health plans. And the health plans have looked at Medicare Advantage and the Medicaid programs that they're invested in as those are really their profit centers, because taxpayers are paying more to the health plans for all the people in Medicare Advantage, which now is about a third of the population. But I think that Medicare patients don't understand that not only he who holds the data makes the rules, he who holds the dollars makes the rules. And in managed care, all the dollars go to the health plan, but then they all have the power to say no. And I also know for certain that people don't understand two things about Medicare. Patients don't understand two things about Medicare. One is that if they choose to disenroll from Medicare because they find it's being restrictive and they've got other sources, if they disenroll from Medicare Part A, the hospitalization, they will lose their Social Security.
That's right.
And the other thing is if the doctor says Medicare will not allow this treatment for you, and the patient says, well, that's fine, I'm going to pull out my pocketbook and I'm going to pay for it. And the doctor would have to tell that patient that would be fraud for me, so I cannot take your cash. And so these are two things that will restrict access to care and not allow the patient to even protect themselves. And those, at least those two things that I said, really have to be changed at a congressional level.
Wow, yes. So if you were to summarize, how do you see physicians preserving the patient-doctor relationship? In, you know, those of us that are, I'm rural practice, I'm in an intimate office. How can I preserve that as these insurgents are coming in left and right?
I still think that for patients, I mean, I'm a nurse and I worked with a lot of doctors and a lot of patients, but I think for most patients, the doctor is still a very special person to them. I think the physician has a lot of clout with the patient, and particularly if you're truly ill, like you're not just going in for a well baby check, and even there, I think there's a lot of clout with the physician. My concern is that the physicians are losing their clout, and as the trust level goes down, right, because the physician starts working for someone else, then the physicians will no longer have the clout that they could use today to help turn the entire system back to the patient being the patient-centric. And so I think the doctors have to use the clout today while they have it in order to start telling their patients what's truly going on in healthcare and how in danger they are of having outsiders determine whether they can and cannot be treated, what they can and cannot be treated with. I think that every doctor should tell their patient, these are the things, the protocols on the computer screen. I am limited to what is on the computer screen unless I spend an extensive amount of time explaining why I, the physician, want to treat you this way. And you need to understand the power of outsiders because you do not pay the bill in healthcare. And I would love it if you would pay me directly and I could have a direct practice and not have to deal with insurance companies or government. And so can you, the patient, help me? Can you start thinking of perhaps a health sharing organization and start moving towards cash so that I can also feel more free to move outside of the current controlling system? And I would tell them, you know, the electronic health record is not confidential and HIPAA does not protect their privacy. And as a matter of fact, the federal government says between business associates and covered entities like health insurers and hospitals and others, that there are 2.2 million entities who could potentially have access to medical records without patient consent, plus all the government agencies. So I think there's a lot that a physician can do to help to turn the patients the way they need to be turned in order to take back the patient-doctor relationship and the protective relationship that every patient wants when they need care.
Are you seeing this in Minnesota with patients?
Well, what I did see when it came to the electronic health record is when all the mental health practitioners realized that they could not opt out and they thought of themselves sitting there clicking in every word that their patient said and having to submit this information and diagnoses and other things to countless others and having to get onto the state health information exchange. It had to be an interoperable record. Which meant all the outsiders could potentially have access as well online through the internet. They said no. And some of them said, we will leave Minnesota. Some of them said, we will disobey the law. You know, this is sort of where the obligation to the patient comes into play. And we love that this organization here today is looking at how to protect the patients and bring back the power of the patient and the doctor.
That's beautiful. I think we both would agree, as Dr. Martin Fisher said, only one rule in medical ethics need concern you, that action on your part which best conserves the interest of your patient. Thanks, Twila.
Yeah, well, thank you so much,
Does that,
Gina. Yes. Do you have any final comments that you would like to add?
I think we've covered it. Does anyone in the audience have a question that you might have for either Twila or I? She's definitely well-versed in all the ethics.
Question, please come up to the microphone right up here up front, and we'd be glad to take that question right now.
Well, one thing, while I'm waiting just to see if there are any questions here, that I could add is just that patients don't understand the ethical quandary that is happening now probably in the minds of doctors. I remember reading an article where one doctor said, you know, he's just going to become an 8 to 5, he's just going to become like a bureaucrat, 8 to 5, do his job and go home. But a patient who is thinking of their situation every minute of the day hopes for a doctor who will also be, you know, things will come up to their mind later. I remember one patient who said to me that they went to a major institution which basically shut them down and said, you know, we can't do anything for you. But they had gone to another institution before that one, and a radiologist called him up one day out of the blue and said, I have this idea for you, and I think it'll work, and it's very unusual. And so he actually put a needle into a cyst right here and kept emptying out that cyst on a regular basis, as opposed to having the patient forced to, you know, get a tube, right?
Wow.
And so this patient was thrilled that some doctor was just thinking about it and just called them up. So that's what patients really want. Now we have a few seconds left. Do I have a question?
No.
Okay, no questions, but I really appreciate everybody's time for listening to this segment, and I appreciate your excellent answers to those questions.
Thanks,
Actually, if you would,
this was great.
Can you mention your contact information in case somebody wants more information about the agency or Dr. Malik over there?
Sure. Our organization, Citizens Council for Health Freedom, you can find it at www.cchfreedom.org. And I'll just add here, we have little cards on the Protect Baby DNA issue because this is nationwide. There's at least 18 states storing it 10 years or longer. And we have Healthcare in a Free Society, what it is on this side and what it isn't on this side. And we also have little wallet-sized cards to give to your doctor when you want to say no to signing the HIPAA form. So I hope people will, go to our website and contact us, and we'll be happy to send those.
Thanks for being so proactive for all of us, Twila. Thank you all.
Thank you again.
Thanks.